So I'm Melanie Thomas. I'm a physiotherapist by background. And as you can imagine, physios don't do wounds. We just do rugby players, football players, and we do sports injuries. So you can imagine it's a little bit unbelievable, really, that here I am in a Wound Care Today conference, and I'm a physio and I don't do wounds. Eilish Lund was one of my mentors, and she told me many, many years ago, and please forgive me, I'm not going to swear, but she was Irish and everything was feck. So she said, Melanie, you can use any dressing you like as long as you feck in compress it. And I've always taken that on board. So use anything as long as I compress, okay? So that's me, Karen.
Yeah. So I'm Karen Morgan. I am a nurse by background. I've been in lymphedema for about 11 years. And I'm Mel's deputy and I lead on education and research around lymphedema and chronic edema. So that's kind of who we are and where we came from.
Okay, so I'm going to start us off and then Karen's going to go. We're a bit like Ant and Dec, but both of us are still together at the moment. So as you can see, Welsh Government gave us some money. They gave us £1 million back in 2011, and that's because I stalked all the health ministers. Every health minister I met, I followed them around, and that is quite a true story. But every time I met a health minister, within sort of a couple of months, they were moved on. But last one, I've got quite an affiliation for him, Mark Drakeford, he's also gone now, we've got Vaughan Gethin, but actually I haven't got him on speed dial, but I can get a hold of him if I need, which is quite different to England, Scotland and Ireland that we've got in Wales. So Welsh Government give us the money. Chief executives, we've got 7 of them, they all run the health boards, and they're our sponsoring group. Underneath that becomes Lymphedema Network Wales, that's our strategy group, and one of those chief execs sits on our group. And that's really important because things can go up and things can come down. And Karen and I are on that group, and as you can imagine, they really don't know what to do with us. The next one down is the operational and clinical board, so that's where all our clinics sit. And then we've got 3 programs of work. So we've got the service development, lots of things underneath that. Then we've got education and research, and then we've got the innovation. So lots of these programs, they could all be a presentation in themselves, and maybe they'll invite us back next year and we'll tell you some other things that we're doing. So lymphedema, lipedema, lympholipedema, wounds, obesity, that's our bread and butter. So Karen and I are still clinical, we insist on it. If we don't do clinical, we go mad, literally. So normally about once a week we deal with complex patients, and we have all the grots, all the complexities from all over Wales, they come to one of our clinics. And I think one of our big things is we are very compassionate, and we are very, I suppose we've got a lot of empathy for our patients. We never take no for an answer, and if a patient says, oh, I've tried that garment, I've tried this garment, I've tried that, we will always find something else. Or we will say, okay, have you tried this with this? So that sometimes helps. So as you can see here, lymphedema, lipedema, that's what we deal with. This lovely photograph here, that's a stomach. That's a new complex patient that was referred to us a couple of weeks ago, and her stomach actually goes to the floor. She was 60 odd stone, she's now 39 stone, but obviously she can't lose any more because she can't move this huge abdomen, which has got loads of wounds and is lymphedema at the bottom. So the incidence, what am I going to tell you? Breast cancer, we say it's about 20-25%, melanomas, gynae, you can just read it on the screen. The big thing for us is the non-cancers, and those are the ones that we have a lot more difficulty with because certain lymphedema services do not take non-cancer lymphedema patients, and that's criminal. It's not on. In Wales, I'm pleased to say we take anybody and everybody. We love everybody. So move to Wales and we'll see them all, which a lot of patients have done. So chronic edema, we know that cellulitis is a big issue, and when we're talking to commissioners and development, we always say, you're spending a lot of money on cellulitis, we could save that money. Obesity, massive problem, excuse the pun, but actually we know it's increasing throughout the UK, and that has a knock-on effect for wounds and for lymphedema, even more so for lymphedema. Lipedema, that is, you can be a size 10 on top and you can be a size 20 on the bottom. 11% of women have lipedema, and our lymphedema clinics are now getting more and more fuller because of lipedema patients. So 4 cornerstones of care. They're all in there, you know all this. This is probably one of the hardest ones, the exercise. Nobody really wants to exercise. I wear a Fitbit, it tells me I've only done 5,000 steps, because the higher you go in lymphedema, the more you sit instead of being hands-on. And then you think, does it spur me to do a bit more? Sometimes, sometimes not. Compression, again, the hard bit, healthy eating, skincare, massage. And you know all this, but so what? So what's the cost of not treating these patients? This was one of my patients, carers going in 3 times daily, in and out of hospital with cellulitis, housebound. And when I said to her, tell me your journey, tell me where you've been, what's happened to you, and she told me about her 10 wasted years, back and forth GPs, district nurses, tissue viability nurses, dermatology, vascular surgeons, orthopedics. Would you think that an orthopedic surgeon would operate on legs like that? Yes, they did. Lo and behold, she had 2 knee replacements. What do you think happened? Didn't heal, suddenly plastics got involved, and it was a nightmare. Bandaging, she was in garments within 2 weeks. The right garments, the right bandaging. Wounds, still problems on the left leg, but we got her back driving her car, and she was great. Same again, this person hadn't been in shoes, inappropriate treatments. With this gentleman, he had a parlour. In Wales, we have a parlour. It's a front room, it's a posh room that you never go into. But that parlour was like basically a pharmacy room. It had every dressing in there in a box. And because whoever went in changed it because they'd recently had the new latest dressing. But really, that's all he needed was compression. And you can see, we can put loads of gory photos up, and you can see before and afters. That foot was the size of my fist. Obviously couldn't get shoes on. Lo and behold, right bandaging, got it down. And now it's Karen.
Okay, so does it matter, like Mel said, if patients have a little bit of edema? This is probably one of the statements that drives me a little bit crazy, and I do a 360 spin of my head. It's like saying it doesn't matter if somebody has a little bit of diabetes. If you don't do anything about it, guaranteed 100% it's going to get worse, so it needs to be managed. So we're doing a skills zone upstairs around the wet leg pathway, and I want to talk to you roughly about where it came from. So we are passionate about education and raising awareness. So we developed an education unit which is accredited for community nurses to be able to manage chronic edema effectively in the community. So it's work-based credits. We do a bit of theory, then we do practical, and it's about identifying those patients a bit sooner and also about treating those wet, soaking legs. But guess what happened? People can't be released. So people come for study in their annual leave time. They come because basically community nurses, hospital nurses are working from the minute they go in till the minute they finish. The district nurses that we went out with were doing about 14 calls a day. And to me, that, I mean, how is that sustainable for a start? And how can you come away from that environment to develop your knowledge further? So, like Mel said, we don't take no for an answer, we take it as an next opportunity. Okay, they're not coming to us, well guess what, we're going to go and get them. So, we put a bid into the Health Technology Fund to use a video film about a patient's story. We would go to the district nurses, we would work with them, and the aim of the project was raise their awareness, but to see every single patient that they saw on their caseload that day. So of course, straight away, they were thinking of all the patients with the big, gross, leaking legs that they could take us to, but we wanted to see them all. And the reason we wanted to see them all was to try and identify how many patients out there had edema, but it wasn't being managed or recognised. And whether people were waiting for it to become a complication, why can't we just treat it a bit sooner? So that's where our idea came from. So we collected some research. We wanted to do it as best we could. So we used the video, we used some health economics data with Swansea University. We only did a purposive sample of 100 because the project was only for over 9 months. We did focus groups with the nurses because we wanted to understand how did they feel about us working with them. We also had ethical approval, and we wanted to do qualitative questionnaires with the patients as well. So there we went with our cases. I'm not there, I was in Canada when they started. That was very nice, but I soon got on there. And the patients would say to us, what have you got in your case? Coming to do my hair? Where are we going? What's the case? What's in there? Actually, it was full of compression garments, bandages, anything that we thought we needed to treat that patient there and then when we saw them. So we wanted to identify patients, treat them promptly, challenge practice, and reflect with the nurses that we were working with. So what happened? Quite often we were faced with reactive care, not proactive care. So legs, we would see legs that had edema, but they weren't in compression. We would see patients but people were mopping up, so putting a pad on and a liner because they couldn't get an ABPI. So I thought, this is ridiculous. There's research out there that tells us that we can apply a class 1 compression without doing an ABPI, but it's not transferring to practice. So what do we need to do to try and transfer it to practice? So we investigated that. Oh, actually, when we were there, the treatment that we did was 3 levels of support. So like I mentioned to you, we had a case and we actually treated those patients there and then. So level 1 was just like a Salona sandwich or a wool sandwich. It was a liner, wool and a liner over the top. So if you were unsure about their arterial condition or the patient was non-concordant or unable to cope with the compression, you would start with that. Then you would increase to 1 layer of compression and then go to 2 layers. And the care plan, this is the care plan that we used. So we actively treated patients there and then. So we were, one of the nurses would do 1 leg, we'd do the other leg, we'd be talking to them about why we were doing it, the rationale behind why we were doing it, the evidence that was out there that supported us in applying compression promptly, and actually that an ABPI in a huge swollen leg wouldn't really be accurate. So what are you going to do? Are you going to wait and let it get worse and a superficial wound become complex, or are you going to actually try and treat it and move on from that? So the patients we saw, I'm not going to go through all the stats, but just for you to have, we're happy for you to have this presentation. All this work's been published now. So if anybody wants the slides, that's absolutely fine. Patients that were referred on to lymphedema, the nurses we worked with, we also gave the nurses something back. We did a wellbeing session. Because like I said, these nurses, I'm a nurse by background, I'm passionate about nursing. I think we'll all be working till we're about 80 the way things are going, so we've got to look after ourselves. And the wellbeing session included a physio session around exercise, one of our healthy eating videos, and also then, do you want compression? And perhaps you should consider being in compression to look after your legs. So we had a bit of support from industry with regards to that. And we delivered the accredited learning that I talked about, but we did it in their own time while we were working with them, and over half an hour at lunch, and did it that way, really. Okay, so how many patients were swollen? 55%. Now, apologise for the slide, because it's obviously not come over as it should, but the important thing for me is the complex and the severe. Straight away, nurses are asking us to see them, but look at the mild to moderates, the little bit of edema that wasn't being treated. Now, I can guarantee you 100%, if you don't do anything about that edema, it will get worse, because patients are becoming less mobile, more dependent, and they will still be on your caseload. So it's much better to get some collaboration and get them managed earlier than waiting for them to develop complex wounds. The cellulitis, we all know that cellulitis let me go back a minute. Cellulitis can cause lymphedema and can also be a complication of, and that's what money talks with cellulitis. So when you're talking to commissioners, if you can save money and episodes of cellulitis, not only for the patient, but statistically, then you can try and prove the worth of developing a service. Now this, for me, this is 3 months. This is 97 patients, because 3 of them did pass away. And it wasn't because we applied compression, so don't worry about the ABPI. But let me just say, for me, the cost of the dressings are massive. The cellulitis reduction in admission is massive. But as I said to you, district nursing, community nursing, I'm a passionate nurse. And if we can work in a smarter way and reduce the calls to a certain amount of patients to free us up for the more complex patients, isn't that better? And this is what this proved. Actually, if we followed the wet leg pathway and we treat people promptly and we get them in compression early, then we can reduce the amount of visits that we go to that patient. Now, for me, that's massive. The other stuff is massive, but we're not getting any more nurses. We're not getting, we're struggling with the amount of nurses that we have. So for me, that's really important. But the commissioners look at the dressings and the cellulitis, because the nurse is already paid for. So, but for us, it was really important to collect that data as well. There's the lovely P-values that people like. Like I said, it's all published. So please, reference it, use it if it's of use for you to get your services moving forward. And then quality of life. We've had the patient talking, and for us, I think none of us, I don't have lymphedema, I don't have chronic edema. And for me, I really try to understand when a patient says to me, I really don't want to wear compression, because it's a lifelong commitment for them. But it's about them having the benefits and the gain around that, and understanding what their risks are. And I think your role is, as a nurse, is to ensure that the patient makes an informed choice, but also to understand their choice. Even if you don't agree with their choice, it's their choice, but supporting them moving forward with that. As you can see, time back to care, dressing cost reduction and cellulitis, and quality of life, what should have gone up went up, and what should have gone down went down, basically. So this is the wet leg pathway. We're demonstrating it upstairs. Please come and have a look at it. We launched it with the Chief Nursing Officer. It's about proactive treatment of superficial wounds. Don't let them become complex. Don't wait for them, because they will get worse. So by all means, come up and see us and we'll go through that. So this is just why we developed it, because the wound burden is massive. And actually waiting lists for Doppler, proactive, reactive care. So that's why we developed it. This is just the pathway. We all like a little pathway. And it is really simple and straightforward. We've also created a video film with patients. We've got 19 video films that we've created with patients, and one of them is an education around the wet leg pathway. There's our articles that we've published. And I'm going to hand back to Mel to do compression garments.
Okay, so see, I told you we'd be quick. So compression garments. Compression garments are a bit of a minefield in that there are thousands, if not millions, of variants around. The way that we get garments is extremely convoluted. There isn't one simple process. If you're fortunate enough to have a budget, you can procure them directly from a manufacturer. But most clinics these days are going through either prescriptions or asking the GP to also write a prescriptions. And those different ways of accessing garments are causing a lot of waste, harm, delays for patients, frustrations for staff, and really we're not getting the patients to have what they want there and then. And when we talk about thousands of variations, that's not even thinking about all the different colours, all the different fabrics, the styles. Do you want short foot, long foot, regular foot? Do you want a grip top? Do you want a sensitive grip top? Do you want a lace grip top? Do you want black, beige, pink, blue, green, yellow, beige? You name it, they're all there. Do you want a long foot? A long leg. Do you want a short leg? Do you want an extra wide calf? Do you want an extra wide thigh? And when you've got all those different variants, no wonder it gets it wrong, okay? So, what have we done in Wales? Obviously, Wales is always different. And what we felt was there was no standardisation. So a clinic maybe in North Wales would use something very different to a clinic in South Wales. The amount of discount that the North Wales clinic had may be more than the South Wales clinic. The big thing about Wales is it is one purse. So there is no primary care budget, there is no secondary care budget. It's one health board at the end of the day. So prescribing budgets as the same as a procuring budget. So we felt very strongly, let's try and simplify the matter. So we created a national contract. What started out as quite an easy thing to begin with turned into a minefield. And I'm going to be perfectly honest. I love all companies. But like clinicians, I do have my favourites. I have my favourites of certain products from one and certain products from others. And that's the same because of all of us, we all know because it works. The contract didn't give me some of my favourites, so I had to abide by the contract. And hey-ho, that's how it works. But it was more than standardisation. It was more than money, really, as well. You know, we know that we're trying to save money, but we wanted to do this no harm. We did an audit back in, 2013, and we found that certain patients were waiting 42 days to get a garment from a GP through a prescription route. And of those, 50% were wrongly dispensed. And when I say wrongly dispensed, they may have been given one instead of two. They may have been given a class 1 instead of a class 2. They may have been given something, but not always the right thing. Some patients, it caused harm. Some patients, we wanted made to measures and they gave off-the-shelf garments. And you think, how can that happen? You've put a request in. If I put a request in for an aspirin, I'd expect an aspirin drug. But that's not what happens with compression garments, which is a big problem. The other thing we've got in Wales is a company called SMTL. That's the Surgical Materials Testing Laboratory. And what identified there was that some of the garments weren't doing what they said they were doing on the packet. The way that they tested all the garments was the same methodology. So a garment from Medi, Hadnam, Juso, BSN, who have I missed out? Because I don't want to, Sigvaris, any of them, Glory Med, any of them, they were all tested the same way, okay? So we can't say, oh, Sigvaris garments did worse because they were tested on a wrong machine. No, they were all tested against each other. We feel very uncomfortable sometimes when we go into, see all the reps, because I think we need bulletproof vests on occasionally. And there's normally, I'm trying to see, there's one is straight in front of me looking at me, so I've got to be really careful what I say. So, do you think I'm careful? No, I'm not. So, this garment, what identified on this garment was less pressure at the wrist, but it was more in the midsection, less at the elbow. So what that was actually doing was pushing the fluid down instead of pushing it up. And often patients used to say to us, this black garment feels tighter than the beige one you gave me. This class 1 garment feels tighter than the last garment you gave me. This garment feels shorter than the other garment that I had. And you think, don't be so silly, they're exactly the same. But actually what we found out was, no, they're not the same. And certain garments don't do what you think. When you give a patient a class 1 garment, which is like 18, 21 milligrams per mercury, you would assume it's in the middle of the compression. And it isn't. They tend to be right at the end, which is the 18 mark. And we need to know that, because as clinicians, we may decide that we're going to put them in a class 2 then, if they're only getting that 18. Especially if you've been bandaging and you've been putting 40 milligrams of mercury on, and then suddenly you put them in a class 1, which is 18, and then you wonder why they rebound, why that swelling comes back, why that wound comes back. So I think there's a lot more we need to know about compression garments. Have we got it better? I don't think we have in certain areas. This is a made-to-measure garment. The same made-to-measure measurements were sent to 4 companies. I'm not saying which one is the right garment on there, but needless to say, those same measurements were taken the wrong way by each of those companies. You can see that the first one is a lot thinner. See, the foot piece is a lot longer, and then the other 3, they're all slightly different, and you can see that when we put them on. Again, I'm not going to say which is the right measurement. So the process, what do we do? So for our contract, we have a benchtop testing. We have patients on there. We have clinicians, normally about 20, 25 people. And then it's a pass or it's a fail. If it's a pass, it goes on to the next round. If it's a fail against objective measurements, it's out. They're out at that point. And some patients don't like certain garments. They put it on, they put their fingers through them, it threads straight away. Those are some of the type of things. It causes a rash, it causes itchiness, and they're out. Then it goes to SMTL, and they're all tested on the same methodology, and then eventually you end up with the money, so the cheapest one then comes on, but they've already passed the patient opinions, the clinician opinions, the testing, the SMTL testing. That then leads on to an all-Wales formulary, but this formulary is more than about just garments. It's about what are the indications. Have you got mild edema? Then it's this garment. Have you got moderate? It's this. Have you got severe? It's this. This is available to anybody who wants it. We're more than happy to share our formulary with you, but just to let you know, it is changing because our contract is changing September.
Can I just say one thing, and then I'll be quiet then? I think for me, it's about confidence and competence, and I think around education, I'm a firm believer that attending an education doesn't change practice. What it does, it gives you a food for thought. You take it away, you investigate a bit further, and you challenge yourself then. That's why we created the Wet Lab pathway, because we want to give nurses on the ground confidence to actually use the evidence to change their clinical practice. So that's why the pathway is there. So please use it. And come up and see us, and if you want to ask us any questions, you can have it electronically, but let's treat these superficial wounds and wet legs as soon as possible. Thanks.